So I'm Andrew Hall. I'm yellow in the package. I'm from Queen's University. I'm an emergency doctor there and the competency-based medical education lead for emergency medicine, and also work with our assessment subcommittee to work on kind of postgrad-wide assessment tools and processes. I'll just be loosely following along. Also in your package is a nice summary of some of our program evaluation work that I'm hoping to chat about today. So it's widely known, I believe, but Queen's University transitioned to competency-based medical education as a whole as of July 1st, 2017. For emergency medicine specifically, we were the first in our cohort, ahead by a year. So we implemented 1 year ahead of our group. And this served as a great opportunity to learn lessons from it. So we conducted a fairly rigorous program evaluation study involving both local group stakeholders and national stakeholders, including Glenn, who's here, and other folks like Jason Frank. And I'm hoping to share with you two main lessons from that today. So our rapid cycle evaluation process, that's what RCE is in the slides there, involved a 3 months and then 6 months, which was actually 9 months, because we're just doing it now, process of stakeholder interview and data collection, and then thematic analysis of those interviews. Followed by improvements, so followed by redesigning the processes based on that feedback, and then conducting another round of focus group with similar stakeholders. Stakeholders like residents, competency committee members, academic advisors, faculty, program directors, CBME lead, everybody. There's a bunch of themes that are highlighted in the little summary I've provided there. But the two most pertinent for feedback were the following. The first one was really that we learned that CBME processes can really only provide as the kind of framework for better feedback and not actually guarantee better feedback itself. And so there's a quote here I'm just going to read. It's on page 3. I think one of the advertised benefits to CBME was supposed to be that this will enable us to give more constructive feedback and to find areas for improvement and to identify them. But what I think is missing is a bit of a culture change and some training of both faculty and residents about giving and receiving constructive feedback. What's interesting in there is that I was very much embedded in the processes of CBME, as I think most people who are transitioning to CBD are, thinking about processes, thinking about how this will work. Yet this reflects a need from both faculty and residents to highlight and help and provide faculty development on the provision of effective feedback, which is not a new thing. It's just that CBME really puts the microscope on our feedback and makes us all more accountable for our feedback, with it being tracked in electronic systems and things like that. I think implementing a new system is not going to change anybody's behavior in terms of giving constructive feedback. I don't think people are going to do it. It's not comfortable for everybody. So I think increasing the level of comfort for people in giving constructive feedback is important. So to anyone implementing, this big lesson is the processes of CBME need to be coupled with the provision of effective feedback and training around that. The second interesting theme that really came out was that in addition to EPA-based feedback, there was still a need expressed by both residents and faculty for a global assessment, i.e., the trainees and faculty both really like looking at the forest, not just the trees. And I think this is a common and well-documented threat from CBME that's been highlighted in the literature, the threat of reductionism and looking strictly at EPAs. And many residents and faculty expressed to us that something was missing when you just look at the trees. We need a way of evaluating residents overall, like a gestalt kind of evaluation, as opposed to just task-specific evaluations. Because sometimes how you function throughout the day is more important than how you function within a particular case. So again, lesson moving forward for those implementing and for us in our revisions was we need to rebuild back in an old system we had where at the end of a shift there is this, and in emergency medicine it's very common, an end of shift kind of pat on the back. How did things go today? A chat. And there is something in that that is hard to quantify. And so in our next round, our 9-month stakeholders, we've asked more questions about that, and we're hopeful to talk a bit more about that. So again, the last two the pictorial slides there on page 4, that CBME implementation is really a lot about process when you're thinking about it, because often we have limited time resources, so we're thinking we need to get these processes off the ground. And then the real hard work and time then that needs to be coupled with that is to encourage changing feedback culture, which is what this is about. And then the second thing is that there is some kind of special sauce in the process of kind of global evaluation at the end of shifts or at the end of a day in clinic or at the end of wherever you are, that perhaps is part of the forest and we can't just focus on the trees all the time. So I'm going to end it there. I'm like a minute ahead and I can't believe that, but thanks.